All right. Good morning. We're here to present a snapshot of our findings from the risk mitigation guidance evaluation that's been going on. My name is Phoenix Beck-McGreevy. I'm a peer research associate with the team. And next slide, please. So we just need to acknowledge that this research took place on the traditional, unceded, and continually occupied lands of 198 First Nations in what is colonial known as BC. And we humbly acknowledge that we are uninvited settlers on these lands and that the disproportionate impact of the toxic drug supply crisis on First Nations, Indigenous, and Métis people from all over Turtle Island is a result of the historical and ongoing impacts of colonization. We've got here our whole team, including all of the academics and the peer research associates. The co-leads are Dr. Amanda Sloan-White, Dr. Bodan Nosik, and Dr. Brittany Barker. And we're here with funding from the Canadian Institute for Health Research BC, and Victoria Hospitals. Thanks, all of those folks. So we just want to take a moment to dedicate this presentation in honor of our team members, family, and friends that we have lost to the toxic drug supply. We're currently in year 7 of a declared public health emergency in BC. And in this work, we continually remember and honor the team members, family, and friends that we have lost to the toxic drug supply. And we acknowledge all of you who have lost loved ones. Next slide, please. As you can see here, the risk mitigation guidance was released in March of 2020 as a novel intervention to enable prescribing of pharmaceutical alternatives to the illicit drug supply to help prevent COVID and to prevent withdrawal and overdose due to the increasingly toxic drug supply. We received funding for this study shortly after the guidance was released, and the guidance offered support for prescribing of opioids, stimulants, and benzos, as well as medication alternatives to alcohol and nicotine for people who are at risk, suspected, or positive of COVID, combined with a high likelihood of being in withdrawal or overdose. In principle, the availability of these medications would also reduce the risk of exposure to COVID by reducing people needing to go out and into the community to pick up and things like that, but not exactly sure that worked. Next slide, please.
Yeah, thanks, Phoenix. Okay, so what you've got here is a screenshot of the protocol paper, which we published, describing what the study was going to be about and how we were going to go about this evaluation of the risk mitigation guidance. And I'll just apologize in advance. We use the acronym RMG pretty freely, and we'll all be doing that throughout this presentation. If you're not from BC, that might not make a lot of sense, but so we apologize in advance. We love acronyms on our study team. So the objectives of our study overall were to, they're here on the slide, determine the impact of RMG on COVID infection as well as overdose, mortality, continuity of care. We wanted to determine the impact of RMG on the uptake of public health measures to reduce the spread of COVID, as well as take a look at the impact on other behavioral psychosocial outcomes among folks who use drugs. And finally, third, to identify individual, personal, and systemic barriers and facilitators to implementation based on program uptake. From multiple perspectives within the system. So the idea here is really to look at what actually happened in BC after this was released, what actually got implemented, so that we can have a better idea of what we're looking at when we look at the impacts. Obviously, the impacts of this kind of intervention are going to depend a lot on what was actually implemented within communities. The study is really a state-of-the-art, what we call a mixed method study. It brings together multiple data sources, including administrative health data, interviews and surveys with people who use drugs, as well as with health planners and service providers around the province. I'd like to just sort of say that from my experience in doing research over the past couple of decades, rarely do studies have the opportunity to bring together such a broad range of data sources. It allows us to be able to provide both breadth of understanding in terms of the population impact, as well as a really in-depth, rich look at implementation and impacts of prescribing in people's lives. So just briefly, the study was participatory. It was co-designed and conducted with people with lived and living experience, as well as academic team members. It involved a thorough analysis of provincial surveillance and administrative data, cross-sectional surveys and longitudinal surveys with people who either have a prescription or are seeking one, interviews with people who have received or are seeking a prescription, including a subset of interviews with people who identify as Indigenous and live in the Northern Health Region. This part of the study was led by the First Nations Health Authority. It was conducted in close partnership with FNHA. We're not going to be speaking to these findings today. However, we are arranging a separate full-hour presentation featuring these findings from this portion of the study team. And finally, we conducted a series of interviews with service providers and planners as well. And as I mentioned, this was BC-wide. So we took efforts to try to capture folks in all areas of the province. Bernie.
As Karen mentioned, this was a fully participatory study, and participatory community-based research can work in partnership with people who use drugs. It can use an advisory model or an employment model. We actually used all three of those, as well as engaging with an advocacy model. The partnership model was really exemplified when BC Yukon Association of Drug Wars Survivors immediately reached out to Karen and I when the risk mitigation guidance was released. And from there, we developed further roles in relation to advisory and employment, but the initial partners were BC Yukon Association of Drug War Survivors and the drug user organizations that they work with, as well as BC CDC PEEP, peers, professionals for ethical engagement of peers. Next slide. This slide just simply shows the different working groups, which really reflect those multiple data sources that Karen outlined. And it is quite significant that we were able to draw data from two admin databases, but both hosted by BC CDC and SFU. And there were people with lived and living experience who acted as advisors to those groups. All of the peer research associates were members of the consortium. And then within the primary data working group, which is mainly what we're going to talk about today, is partnership, employment, and advisory roles of peer research associates were integral to that work. And I think what's notable is that while we talk about knowledge exchange in other, the important thing that was brought home to us is that people with lived and living experience engage in this research for the purpose of action, and therefore advocacy is critical. Next slide. For this presentation, we're going to focus on implementation and talk a little bit about from the primary data, what actually happened in terms of implementation, recognizing that a policy was released in March 2020, but what did that actually look like from the perspective of people in different parts of the province? And we're focusing here on implementation from the perspective of people with lived and living experience. We're not reporting on the service providers or health planners implementation. Those are separate analysis. We're also going to talk about the impacts, both quantitatively and qualitatively, for people with lived and living experience in relation to substance use, mental health, quality of life, income source, and other aspects of health and wellness. Next slide. This slide speaks to the qualitative findings from persons with lived experience provincially, in which it was highlighted that in order to access the risk mitigation prescriptions, there was a series of steps that one has to scale, starting with knowing about the program, which is the lower step. And I would just note that people had a lot of hopes and expectations when the RMG was released. But that was if they knew about the program. Many people were not aware of the program. They hadn't necessarily heard about it. And those that did hear about it often heard about it through drug user organizations, through peer workers, and often through outreach teams who were operating, for example, in encampments. Secondly, finding a prescriber is often very difficult. And people found that they got a lot of runaround. And I'm going to talk a little bit about the difference in a minute about finding a prescriber in urban and rural areas. But where people did know about it, they could go, they could cycle around through, from their methadone doctor to the pharmacy to maybe a clinic and just almost going in circles trying to find who was going to get a prescription. And that was if they found a prescriber. One of the things I want to highlight is this was introduced into a very medicalized system, often addiction medicine. There are a number of barriers there. And then if you can kind of scale up those steps, and then there's the challenge of actually getting the right prescription for you. And then the kind of daily having to go to the pharmacy for pickups, and then the keeping of appointments so that you don't get kicked back down that set of steps again, only to start over. In our presentation, what we'll highlight is the stigma and discrimination that people often face because of drug use. And I think when Brittany and her team present, you'll particularly see some of the findings related to racism. And obviously this is harder to scale these steps are harder to scale if you're living in a context of poverty and homelessness and past medical negative experiences. Next slide. Next, oh, there we go. So this first person is talking about the difficulty of accessing prescribers in rural areas and the challenge they had. Because there's only a very few kind of prescribers. They did find that video conferencing was made it more accessible for people if they weren't able to actually have a face-to-face. So you can see this person spent from December to February trying to get on safer supply. In the second, the person describes how the nurses helped them to access a safer supply because they got back to you by the end of the day. They're welcoming, they want to help you and try to get you on safer supply or whatever you're doing to. So this person had much easier access in an urban center. Next slide. And you can just flip the whole thing up here, Karen. These two participants speak to what was commonly encountered in terms of medicalization. It was a really traumatic experience to get onto safer supply of substances. I've never been treated so horribly by a doctor in my life, right? And since then, my doctor has dumped me. So it's been a struggle. And people faced a lot of barriers in terms of being able to be honest about drug use, being lots of assumptions that they faced were that, well, you're just going to misuse whatever you're prescribed, which is all part of that medicalization and stigma. And then I think further the criminalization. This was particularly acute for parents. And I just want to highlight a quote from one of the participants. "I hate seeing my doctor. I'm always scared if I've been using because I have a daughter. I don't tell them anything, and they say one side of them say, it's confidential, but then the others, there's a big huge poster on the wall that says I'm a mandated reporter. So I know many women and mothers that won't tell anybody anything, even to get counseling or help. They're scared out of their minds." Next slide, please. Getting the right prescription was also problematic. And that really involved three things: trying to get the right medication. And for many people, they had to go through a series of steps in terms of doing some of the OAT medications first. I knew from the beginning I only wanted Dilaudid. I tried to self-advocate, but of course the doctors had to go through the steps necessary and had to take other substances and prove they had severe side effects for me. So I did OAT through them. I've had bad reactions to both Suboxone and Cadian, borderline seizures. And so people, you know, talked about that they were required to also accept OAT, even though they may have been unsuccessful on OAT before. And there's nothing particular in the guidelines that said it had to be implemented it that way. Next slide. In terms of getting the right prescription, also getting the right dose, and many people talked about the inadequacy of the opioids, particularly. And again, this was somewhat regional. Remember that a lot of the implementation was in urban centers, and a lot of people highlighted, you know, that they were taking fentanyl, and that's hydromorph is like aiming a rubber band gun at a tank. And so just the lack of potency for some people, and then the inability to use them to have smokable options. One thing that's not mentioned here is also the range of stimulants was quite limited, and many, you know, if the particular stimulants worked and there was a good fit, that was great, but oftentimes they found that the stimulants had no effect. And then of course the issue of not being able to smoke was particularly acute. And this person said, they suggested we crush them up, smoke them, which is disgusting. I did all those experiments. None of them worked. I tried crushing up increasingly larger quantities to inject, and I was able to substitute for another dose. At that point, started diverting instead. And just highlight that participants, you know, if they were going to not use their prescriptions, it was usually for reasons of not having an adequate dosage or a route by which they could use their supply. Next slide. The last slide speaks to, you know, the ability to stay on the safer supply. One of the challenge being that if you don't have delivery and you can't get to the pharmacy every day, you're missing your appointments, and doctors don't want you to miss more than 2 days. So they cut you off and you go back down. And the next quote is, I would say it's definitely harder to go to work kind of spontaneously, which is what I want to be doing. So really difficult to manage, you know, things like work, seeing family, and other kinds of living, important things for living and quality of life. Next slide. Over to you, Catherine.
Thanks, Bernie, for providing that rich insight onto what it looked like when people were accessing. As noted earlier, we did gather the experience of people with lived and living experience via survey that was conducted across all regions of BC. Findings from this survey echo much of what we've already heard from Bernie in the interviews about the challenges associated with the implementation. I'm first going to start with a description of what we heard related to accessibility and barriers of RMG, what the intervention looks like for people, and whether there were differences by gender, age, or urban setting. The survey itself was conducted from October 2020 to November 2021. Recruitment was done by posters, flyers, word of mouth, and through drug user organizations. So this is a convenient sample of 352 people. To be eligible for this survey, people either had to have received a prescription or be trying to access an RMG prescription. We really wanted to capture that second group of folks who weren't able to access a prescription to make sure that we were able to speak to issues encountered by those that were unsuccessful. Next slide, please. It is a key finding here that regardless of whether or not people received a prescription in the end, barriers were really common. Here, barriers reflect issues that people encounter that maybe hindered or challenged the process of getting a prescription. We've grouped them into 4 different kinds here. So as you can see, structural barriers reported by 3/4 of our sample. This reflects concerns and lived experiences of criminalization, child apprehension, and stigma in healthcare. Another barrier that we saw by over 3/4 of our sample reflects factors such as clinic hours, closures, distance, not knowing where to go, and wait times. These were barriers that were related to the setting itself. When we look at personal barriers, that was reported by 2/3 of the sample again. This includes anxiety, depression, not being confident that the intervention will work, not having time. And again, our least common barrier, but what was still reported by over half of people that conducted this survey, were interventions or barriers related to the intervention itself. So this might be not being able to get the preferred medication, the type or form, or not being able to afford it. Next slide, please. Here, I'd like to talk and look at predictors of whether someone received a prescription. Here, what's termed access, and whether they reported barriers of different kinds or not. So access did not differ by gender or age in our sample. It was driven by living in a large city though. So we use the Statistic Canada definitions for large urban centers. And so in BC, that includes areas colonially known as Vancouver, Victoria, Kelowna, Abbotsford, White Rock, and Nanaimo. And then all other locations across BC were located in small centers or rural areas. So again, kind of as I reported earlier, barriers were just really common overall for folks trying to access RMG. So we did see that few differences emerged across gender, age, and urban setting. There was some evidence that women and gender diverse folks were more likely to report barriers related to the setting itself and to personal circumstances, whereas older folks and those living in smaller or rural areas were slightly more likely to encounter barriers related to the intervention itself. Next slide, please. Among a subset of folks who got a prescription, so were successful in accessing RMG, we did ask a series of questions about the process. So these folks generally met with their prescriber in person, although a sizable minority, about 1 in 5, met via telehealth. So this includes phone, web-based services, and includes First Nations Health Authority VSUP service, which is an online phone line. Most folks did pick up their medications at a pharmacy, but again, a sizable minority, over 1/3, reported that receiving them through delivery was possible. So we do want to note that people could receive multiple different ways of accessing their prescription, so it doesn't always add up to 100% here. It is key here that 43% had a dose that was sufficient to prevent withdrawal. This is really relevant here because preventing withdrawal is the floor of what we can envision. We know that people's motivations and goals differ, and many go beyond simply preventing withdrawal to experiencing other effects related to both health and pleasure. So it is relevant here that less than half of folks even reach the floor of preventing withdrawal. This has really major implications for what we can expect when it comes to retention and outcomes, particularly separation from the toxic drug supply. Unfortunately, within the survey, we also did hear that of those that had been recently stopped by police or bylaw officers, 23% had their medications taken during an encounter. Next slide, please. Here, we did see that medication delivery was more common in cities, while those in smaller centers and rural areas were more likely to report with meeting a prescriber virtually. And as well, finally, numbers are so small that this should be interpreted with caution, but men and those in smaller centers or rural areas seem to be more likely to have their medications confiscated by police or by bylaw officers. This is a phenomenon we do need to know more about as we continue to advance policy and practice on prescribed safer supply, particularly as we think about meeting the needs of folks that live outside of the major centers, city centers in BC. Next slide, please. I do want to take a moment here. I would like to acknowledge that the following slides I'm going to be speaking about people's experience with children. I do recognize that this may be a difficult topic for folks and would encourage you to take care of yourself. It is okay to step away and come back when you are ready in whatever capacity that may look like. You can advance forward, Karen. Thank you. So right now we are running some analyses that look at people's experience of RMG in the subset of participants who reported having 1 or more children under 18. This group was really roughly the same in terms of whether they received a prescription, and they reported similar prescription types to the full sample itself. Within this group here, there was an even balance of men and women, and no gender diverse folks in the full sample reported having children. We see that the characteristics of this subgroup are generally similar, with 66% living in urban areas, 47% reporting stable housing, and 37% in a relationship, married, or partnered. During the survey, we did also ask folks about where their child or children were living at the time of the survey. Here we see that 66% reported that their child was in the care of a family member, and a very small minority, only 9%, had their child in their full-time care. We do recognize again that these findings are based on a very small sample size and should be interpreted with caution. Next slide, thank you. Earlier, I did mention and explore some barriers related to accessing a prescription. The barriers I've identified here on this slide fall under that structural barrier category that 75% of the full sample reported. These barriers concern parenting responsibilities and fear of child apprehension. Overall, 22% of people who had children under 18 reported one or both of these as being barriers to accessing or receiving a prescription. At baseline surveys, 15% of folks with children reported that parenting responsibilities are a barrier to accessing a prescription. Of these folks, 70% were women and 29% had their child in their full-time care. The next barrier, again, 15% of the sample reported at baseline, reports the fears around asking for or getting a prescription would cause their children to be taken from them as a barrier to RMG. Of these folks that reported this barrier, 70% identified as women and 41% had their children in their full-time care. We do recognize that these are really difficult topics to talk about, and please note that it would not have been suitable to inquire further about any connections between child protection services and prescribed safer supply right now in the survey. Next here, I'm going to mention the RMG impacts. So we're going to look at what the impacts of receiving an RMG prescription were on people's substance use, their mental health, quality of life, income source, and other aspects of health and wellness as well. It is a strength of our study, as we mentioned earlier, that we are able to look at both quantitative, so these survey findings and these numbers that I'm providing here, as well as those other rich qualitative data that Bernie talked about earlier. So as we noted, we conducted an analysis of administrative health data, and these analyses also speak to outcomes about people's health. We aren't presenting those findings here today, but feel free to ask questions if you have them in the end of our presentation. The next couple slides here feature findings from a subset of 161 survey respondents who were followed longitudinally for approximately 12 weeks, completing the survey 5 times. These are people who at study enrollment had either received a new prescription within the past 2 weeks or were seeking out a prescription. Some of those who were seeking a prescription managed to get one during the follow-up period and others didn't, as well as some who had prescriptions at baseline stopped taking or discontinued their prescriptions. This means that we're able to compare people who had a prescription at a given time point to those who did not. This table here shows the picture of health and wellness in the full sample. So this includes folks who both had a prescription as well as those who did not. We looked at 5 outcomes. So within this table here in the rows, in row 1, you can see that the proportion with a prescription at any given time point was pretty steady, ranging from about 43 to 50% of folks. In terms of outcomes, we did look at health-related quality of life, depression, anxiety, frequency of substance use, and criminalized income sources. So these are lots of questions that are asked on the survey on a scale that people can report on. If you look across the column at people's scores over time, the main message here is that there was really little change in what happened in these measures. I would like to note that this is not an indication of the impact in RMG, and this table here includes everyone, even folks who weren't on a prescription. We show this to show the average change that we picked up overall, which is really important to the interpretation of our findings. If anything, there are very slight improvements in people's experience of health and wellness over the 12-week follow-up period. There's slight improvement of quality of health. So here, higher scores are better. Mood or anxiety here, lower scores are better. We saw really no change in the frequency of accessing or using the unregulated drug supply. It does stay quite high, and a slight decline in reliance on income sources that are criminalized. And for anyone who has questions about the scales we used or measure these outcomes, please do reach out. Understanding that there's little change in the measures overall, we can now look at the differences depending on whether someone had received a prescription or not. This is the test of RMG effectiveness. In these analyses here, RMG exposure could vary over time. This is really important because people shifted between having a prescription and not having a prescription over that 12-week period where they were followed up. In these statistical models here, we controlled for both sociodemographic characteristics, location, baseline substance use, parenting, and criminalized experience. We found that the receipt of an RMG prescription significantly predicted improved mood, so lower depression scores, and it did not predict improvement or any change in the other outcomes during the 12-week period. When we combine these with the findings from the last slide, the overall interpretation was that there appeared to be slight improvements in health and wellness, but these changes didn't appear to be associated with whether someone had a prescription or not. The exception was for depression, which did appear to be lower among those with a prescription. To give you a little bit more insight into these outcome analysis, these graphs here illustrate the change in outcomes over time, given RMG exposure and controlling for those participant characteristics that I've mentioned. Here we've just selected two as an example. So the first graph you can see on your left-hand side shows the changes in depression scores among those with RMG medications. So that area shaded in red, and those without RMG medications, that area shaded in blue. Lower scores on the scale are better, and the shaded area shows the variation across people's score in each group, the standard error. You see that over the short time period covered here, exposure to RMG medication is associated with lower depression scores. The right-hand graph shows the same for folks with RMG and without a prescription, but this one is for illicit substance use, and it's really high throughout the 12-week period and does not really change. However, I do want to highlight that these statistical models only show part of the pictures of people's experience. This can really vary in subtle and personal ways over time, depending on a whole host of factors that we can't capture in the model and through the survey. For that, I'd like to pass it back to Marion and the qualitative data team to provide some more rich insight into what people had to say about accessing RMG.
Thanks, Catherine. Can you pull up all the pieces here? I think you really mentioned a good point, and a lot of participants in the 55 qualitative interviews that I did with folks with lived experience across the province, that there was so much going on in their life in terms of COVID, where they were living, you know, what was happening in their families and their friends, that sometimes it was hard for them to tease out about whether it was the RMG or something else that was contributing to the impacts. However, we did ask them about, you know, how they thought RMG was changing their lives in any way. One thing that they said is that many people had a decrease in overdoses, or that there were no changes in their overdoses. And several commented that they actually thought they were at less risk of overdose due to the RMG. We definitely talked about the impact of RMG on withdrawal and cravings. And some of those extreme symptoms that people talked about, like puking their guts out or feeling like they want to die or shitting my pants, were definitely reduced. Consistently, though, as Bernie mentioned earlier, participants told us that those dilaudid tablets as a replacement to the opiate illicit drug supply just were not strong enough, that it doesn't do the trick. And they were absolutely left white knuckling between their doses as they were attempting to use it as a replacement. And so while some people did have a decrease in their illicit drug use, with a few people completely stopping for a period of time using drugs like fentanyl or crystal meth, most described continuing to supplement their RMG with illicit drugs. Some discussed how an OAT such as Cadium had helped with withdrawal, thinking about some of the stuff that Bernie talked about earlier, that it was, you know, problematic for some, but for others, it was actually a helpful part to deal with withdrawal. And definitely so that then dilaudid could be used as a supplement during the day. And a few others who had access to fentanyl patches prescribed and specialized programs definitely described that provided relief. Next slide, please. So having an RMG prescription meant that people didn't have to hustle as much. And many participants talked about that, about the ways that they made money, such as stealing, selling, or trading their possessions were greatly reduced. One person described having money in their bank account and was paying off their student loan. Others described having more time to get things done, to take care of themselves, to look for housing, to attend to mental wellness, and just describing about getting their life back. Some engaged in less criminal activity, such as shoplifting or drug trade. Here the participant said, I used to steal every day, but now I don't barely ever steal at all. It's when we get sick is when we end up stealing. This is the first year that I haven't had a court date in like 15 years, which sounded pretty amazing for them. RMG also, was sort of conceptualized as empowering for some. Here, this participant describes buying food with half the money she normally would have spent on illicit supply. And when I came home carrying some snacks and stuff, I just felt so good. I get to put this little bit of food that I have in my fridge and in my cupboards, and it felt empowering. Next slide. So several people were experiencing better sleep, reduced anxiety, and improved attention span. And maybe we can see some of those connections to that just increase in mood that we saw in the quant. Here, the participant describes how I can actually sit in a room and sit at a table and have a meeting with people for an hour or 2 hours at the most, and just sit there and feel comfortable. People also described various ways that their health had improved, reporting changes such as reduced pain for some, infections, lung issues, that they were able to eat more regularly, that definitely they were spending less time out in the cold. Here, this participant says, I definitely look a lot healthier and feel a lot healthier. Yeah, I'm just now kind of on a steady dose. I don't think it's a miracle pill, but I think it's definitely helped. I feel really positive. Like fentanyl just takes your body, right? It makes you feel like a bag of shit. Finally, participants identified how people that were there to support them in wraparound support services, etc., were making a difference in how they felt, because that's the first person in 10 years that's actually made me feel like I matter. Next slide. And here's for Phoenix.
So the next section is going to touch on some of the recommendations that we heard from people with lived experience on ways to improve the program. It's important to note that while there were some barriers and challenges to the program, a lot of people felt like it was at least a half step in the right direction and didn't want the program to be taken away. So we want to make sure that while we are kind of focused on the critiques, we definitely did hear some positive feedback, but there was definitely some things that we heard about ways to improve the program. They need more physicians, including general practitioners, to be able to prescribe in all areas of the province, including decoupling this from OAT. People wanted to be treated with respect and dignity in all services. There's a need to work with prescribers to get the right drugs in the right combination, and that includes not just what is currently available under prescription. Hotels and housing facilities with services that are offered on site and options that are focused on dealing with chronic pain, which was reported by a lot of our participants, and access initiatives such as medication delivery and having carries, not being handcuffed to the pharmacy. And finally, outreach services for those who do not have housing facilities with supports built in. Some people had these options, but they were not universally encountered by people who were receiving a prescription. Next slide, please. So what is missing? Some of the recommendations. People indicated that they would like to be able to access optional wraparound support, such as mental health services or counseling, including some integration of housing and assistance with navigating or accessing social assistance benefits were found to be extremely helpful by the people we talked to. Some folks said that the same building serves as 3 different things and we make it work. They know everybody, there's counselors and stuff, and they always ask, hey, how's it going? Hey, how's it going? Hey, I'm doing great. I'd like to get my script and go now. Bye. And other folks reported that having a close-knit group of workers that were directly involved with my day-to-day care allows the doctor to have a hands-on or eyes-on my situation as we progress through the beginning stages of this trial to see if the patch is significantly going to work for me or not. I have interactions with them daily to see how my mood and my attitude, and if it's making me drowsy, my team will come to me wherever I'm at. And then when my prescriptions are up, I'll usually do a phone call with the doctor over the phone, or every couple of weeks go in to see him, and it's been working out great. Next slide, please. Recognizing the expertise of people who use drugs was also brought up as a big way to improve the project. Sorry, my cat is biting my toe. Excuse me. One of the participants said that they were talking to a doctor, and the doctor said, "Why don't you take Suboxone?" And he said, "Well, it was affecting my breathing. I chose to be on methadone instead." And the doctor goes, "Methadone's supposed to affect your breathing, not Suboxone." And the participant said, "You're a doctor. You have a PhD in the human body and reading. I have a PhD in sticking dope in my body and how it feels." So really just highlighting the need for recognizing the expertise of people who use drugs. Next slide, please. Doctors also need more authority to prescribe stronger drugs, such as fentanyl and whatnot. The doctors need more authority to prescribe stronger narcotics. RMG is not what I need and it's not what I want, but it's what we'll have to do for now. It's not smokable, it's not nearly strong enough. When I take the morphine, I just don't like the effects, any of it. It's not the relaxation promise like the fentanyl or the heroin. It's frustrating. It's like we're thankful and grateful that the government is doing something, but at the same time, we're frustrated that it's just not enough anyway. They thought it would be enough when they advertise all the time how much more powerful fentanyl is than morphine. So it's just really highlighting the disconnect between all of these like fentanyl scare ads and PR campaigns versus like, oh yeah, fentanyl is so crazy and horrible and strong, but we're going to give you 8 Dilaudids and hope that helps. Next slide, please. People were particularly vocal about the need to have access to heroin and access to smokable and injectable fentanyl and more stimulant options in smokable. They said that the people that they speak to who use meth, like they don't like Dexedrine or Ritalin. They've already tried that in their younger years when doctors prescribe that to them. They don't really like the options that are available. It definitely needs some work. So, I mean, most of us who use drugs have been through every type of prescribed option available before we get to the street supply or during the course of that progress. And so to keep going back to these same things that have been tried over and over again is just, it doesn't make any sense. Next slide. People want to work with their doctors in a collaborative process where their goals help guide the process, not necessarily just the doctor's goals. They can handle collaborative process, make it a consultative process as possible with your client, or else it's not going to work. Your goals are trying to help someone, it's not going to work. It's not really them sort of helping to guide that process. They also reported the need to move to lower barrier models within and outside of the healthcare system. Many people recommended a compassion club model. One participant reported that they'd like to see it move into more of the compassion club model and a program run by peers would be ideal instead of doctors who are super apprehensive of prescribing. And I'm going to pass it back to Karen.
Great, thank you, Phoenix. Just to mention the limitations of all this information we just presented. The surveys and interviews were completed by a convenience/snowball sample of people who responded to our study flyers. We took pains to try to make the survey and the interviews as accessible as possible by offering different options for people to connect in, but it will have an impact. Findings presented offer insights into early implementation and impacts. They may not be generalizable to the full BC population or to specific programs operating in BC in very different ways. Finally, findings speak to a very specific and limited form of what is sometimes considered to be prescribed safer supply. They really don't speak to the impacts of safer supply as a whole and shouldn't be taken for that. They speak to the early implementation of the RMG. So a particular form of prescribing at a particular point in time. And that's relevant for how we think about what these findings say. I'll do this as quickly as possible. These are some of the key messages that we came up with. And I'll do them in 2 chunks. So first, implications for the implementation and impacts of RMG in British Columbia. First, RMG prescribing was implemented in the context of a pandemic, housing shortages, the criminalization of people who use drugs, and in the absence of mechanisms to support uptake or ensure equitable access. It was just thrown in there. The system existed that underlay the services and supports available for folks who use drugs in BC was already overburdened. It was already contending with a public health emergency at the time that COVID began and the RMG was published. This is relevant because without mechanisms to support the uptake or to ensure equitable access, this is why there were so many limitations, right? This is why we found what we did around implementation. It really limits what we can expect to see in terms of the impacts at this time. But irrespective of these implementation issues, as Marion noted earlier, people who use substances, the prescribers and the health planners all alike did not want this intervention to stop. They encouraged continuation and improvements. And as Phoenix just ran through, they had lots of ideas for how to improve it. So we have lots to work with. I'd like to just mention for a moment, it can seem at the beginning that, or at least first impressions from seeing these results, that the findings from the interviews, those rich stories that we heard from folks, may conflict or seem to be conflicting with what we found from the survey, but they actually aren't. And here's why. Data from a survey are the average of what happened and what we can attribute to RMG relative to a control group. And that's a different question than what the interviews, which were conducted with a group of folks for whom RMG was kind of working for them. They had figured out how to navigate the system and those barriers. They had figured out how to get their prescriptions in a way that was going to work for them. These folks were seeing benefits, and that's really relevant. Together, these findings point towards the need for improvement of the intervention. It can work under some circumstances, and it just needs to be more than what it was. There are many potential underlying reasons that could explain why we didn't see a population level effect on health. It may mean that the prescriptions that were offered as part of a suite of services were just not sufficient. And here, as Catherine mentioned, the fact that less than half of people even got a dosage that was sufficient to prevent withdrawal is really relevant. And finally, the implications, we can think in a bigger picture about prescribed safer supply. Prescribed safer supply is an emergency response to an unpredictable, increasingly toxic, unregulated supply. It seeks to reduce harms, and that is not the same thing as overprescribing. Implementation successes and challenges carry implications for what we can expect around the impacts of these kinds of interventions, and particularly in the context of ongoing criminalization. As you heard earlier, it wasn't rare that folks had their medications that were prescribed for them confiscated by police or by law. What we know from research on the principles of system design is that a system of care needs to be based on, it needs to offer multiple services with a range of readily accessible clinical interventions. And we're talking same day services for people. This is important because when you introduce a new service into an existing system, like RMG was in BC, it's not being introduced in a vacuum. It's having ripple effects throughout a system. Other types of services like OAT and detox, they're going to feel the effects, and vice versa with RMG. And what we really need is an effective system in which the services are all speaking to one another so that they're leveraging and maximizing the impact of each. So if we think about this, prescribed safer supply interventions can add to an existing service landscape. But in BC, implementation was not really widespread, and there were significant regional disparities. None of the introduction of a new service such as this replaces the need for system enhancement efforts overall. That's what we see these findings as telling us. Once this presentation is posted, and you'll have access to the slide deck, we've just included some other resources here related to this work, including the link to our protocol paper, some infographics and knowledge updates that were prepared from Amanda's Longlight's team at the BC CDC, which include all the findings around the surveillance data. And finally, a shout out to the National Safer Supply Community of Practice, which has a wealth of really great information that can help us to interpret this. Thank you so much. We hope you'll reach out if you have questions or comments. And with that, I'll hand it back over to Phoenix to moderate a Q&A. And hopefully maybe people can stay for a few minutes and we can have a bit of a discussion about this. We welcome your questions. Thank you.